I think that there are certain agents that are so foundational in some diseases that they will remain. Whether they remain first line, maybe not. Maybe they'll go to second line as we see things evolve with new agents. Some of these drugs have been very effective in the diseases in which they are used to treat patients. I do think there's long-term place in therapy for these, and I think that we'll still be using these.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. Today we're talking with Rowena Schwartz, known to many as Mo, Professor of Pharmacy Practice at James L. Winkle College of Pharmacy at the University of Cincinnati in Cincinnati, Ohio, about what oncology nurses need to know about antimetabolites. This episode is part of a series about drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Mo.
Oh, thank you for having me.
To get started, can you tell us a little bit about antimetabolites and how they've been used in medical care and cancer care?
Antimetabolites are relatively old agents. They're some of the oldest anti-cancer drugs that we have. They were developed to be similar to naturally occurring compounds that are important in cellular production. They are similar but not the same. So they sometimes will bind to an enzyme important for cell proliferation. And because it binds to an enzyme, doesn't mean that it helps the enzyme. It may block it, and that may cause cell death. And so they've been used for a long time in oncology. They're used in other areas as well. There are antimetabolites that are similar to, say, components of a bacteria that, again, block the natural processes of that bacteria and are used as antibacterial. So it's kind of a logical way to go in and attack different cells.
You alluded a little bit about how they work, but can you give us a little bit more information about what the actual mechanism of action is within the body?
There's different classes of antimetabolites in oncology. If you think of the structure of DNA, there is purines, that adenine and guanine. There are pyrimidines, which are things like cytosine and thymidine. And then in RNA, there's uracil. So some of the antimetabolites are either purine analogs or pyrimidine analogs, meaning they look very much like the natural parts of DNA. And by being incorporated into the DNA, they cause cell death. There's also a class of antimetabolites that interfere with how we use folate in the body, such as methotrexate is an obvious one. And these are called folate antagonists. So the type of antimetabolite, they're categorized based on the structures and how they interfere with the components of the cell. They work very different. Within a class of pyrimidine antimetabolites, they have different toxicities and different actions.
That's a lot to remember. But I think that the more you work with this, the more you start to understand because you see the medications that go along with those.
I think you're right, because when I think of antimetabolites, the way I think of them is how they're used. So when I talk about pyrimidine analogs, fluorouracil, 5-FU, is an analog of uracil. Cytarabine or Ara-C or cytarabine is an analog of cytosine. So you can see that kind of makes sense when you think of specific agents.
Wow. I wish I'd had that information like 30 years ago. So you shared some of those subclasses of the antimetabolites. Can you give some examples of some of the newer agents within them?
So, it's funny. When I think of newer agents, chemotherapy doesn't pop to mind. But I think over the course of my career, I can think of agents that are a little bit or more. I think of agents that have come out more recently. And so I think of things, and when I say this is going to be kind of funny. I think of gemcitabine because that was a relatively new antimetabolite. Pemetrexed is a newer antimetabolite. But even as I say those sentences, those drugs have been very much embraced in practice and are cornerstones of some treatments. So they're not really very new anymore. Some of the other agents that I think of a little bit that are a little bit newer are some of the purine analogs. And people are really probably very familiar with things like fludarabine. And again, that's been out for a long time. So these are agents that have been around and have really found a way in practice.
Can you share some of the common toxicities and adverse events associated with antimetabolites with individual agents and maybe as the subclasses as a whole?
I think this group has a core group of toxicities that you can think of with the agents. Because these drugs interfere with cells as they're dividing, a lot of the toxicities that we associate with many of the antimetabolites are their effect on rapidly dividing cells in the body. These are the drugs that we think about when we think about GI toxicity in terms of things such as mucositis and diarrhea. These are also the drugs that interfere with cells that are dividing, so bone marrow. So bone marrow toxicity, again, is one of that kind of class toxicity. Now, that doesn't mean that every antimetabolite has a lot of mucositis associated. Doesn't mean that every antimetabolite has a lot of bone marrow suppression. It depends a lot on the dose and the regimen you use. But those are kind of class toxicities that I think of. And then we get into those toxicities that are either agent specific or subgroup specific. And let me talk about the subgroup first, because I think that is kind of interesting. The purine analogs, and those are things like fludarabine, clofarabine. Those drugs are very toxic to lymphocytes. And because they're very toxic to lymphocytes, these are drugs that we use in lymphocytic diseases. But that also means that these are drugs that we get immunosuppression because of the toxicity of lymphocytes. So these patients have risk of infections because of their decreased lymphocyte activity after receiving these drugs.
To that point, so with the lymphocyte activity being affected, would that also mean there'd be more of a long-term chance of infections and different types of infections, like viral infections and that sort of thing?
Exactly. And so the duration of the impact on lymphocytes is different for the different agents. So for fludarabine, it's months. And so that we know after fludarabine that you have to be very cautious of opportunistic infections, whether it be fungal or viral or other opportunistic bacterial infections. And so that's more of a class effect. Exactly. Now, if you're talking about specific agents, if I said an agent, it's normal to think these are the toxicities that I see. So I'm going to use an example, gemcitabine. Gemcitabine is, I think gemcitabine is a chemotherapy that is relatively well tolerated. It has some bone marrow suppression. It doesn't cause very much nausea and vomiting. But one of the things that is unique about it is it has this flu-like effect for the first 24 hours after you receive the dose. You need to warn patients that they may not feel very well, that they may take Tylenol or an antipyretic for the first 24 hours. So there are specific class effects, as I mentioned, and then there are specific agent effects.
Perfect. So that's why it's really important to not just rely on your memory, but going back and looking those drugs up in UpToDate or in Micromedics or whatever those resources you might use so that you can get those specific agent effects.
I think that is really important. If I don't use a drug often, I will always look it up again before I do any kind of education for a patient. I have been working with 5-fluorouracil since I was a new pharmacist, but I don't use it routinely in my practice. So I always find myself reviewing it just to make sure that, like, a nuanced side effect that may be very important for a patient, I will go over.
Thank you. I think that's really helpful to remember. What are some of the pharmacology-related strategies that might be used to prevent or manage some of the toxicities?
So these agents are important in another way besides their normal toxicity, because their toxicity profile, as well as their activity, is very dependent on the dose and the regimen used. Let's use an example of 5-fluorouracil. Many people use that as a continuous infusion for treatment in GI malignancies. The toxicities that you see with a continuous infusion are different than when you use, say, a bolus of that drug. So knowing the toxicities and knowing how they are related to the regimen is really important. So with that, one of the things that we do is when we have toxicity, we may do things like dose modifications, holding dose or dose modifications, and decreasing dose for the next cycle may be something that would be important. As I mentioned, bone marrow suppression is one of the toxicities of this class of agents. And so using growth factors, filgrastim, pegfilgrastim, may be something that is important, especially when we're looking for curative intent therapy for patients. Then we go into the toxicity management that are very treatment specific or drug specific. One of the ones that I just learned this year at the ASCO meetings in June. There was an abstract about using diclofenac topically for the hand-foot syndrome prevention with capecitabine. So capecitabine is an oral prodrug of 5-fluorouracil. And so one of the things we see when we use it is that patients get this hand-foot syndrome. And so they showed in this study that when they use this diclofenac topical, they had less of the hand-foot syndrome and less dose reductions because of the hand-foot syndrome. So it's always interesting to look at new things that people are doing and to look at agent-specific strategies for toxicity management.
That is such a cool thing. I remember working with patients taking capecitabine and how it was so hard on them to have such severe hand-foot syndrome that we had to dose reduce on them because then they were so concerned that they may not be getting an adequate dose to treat their cancer. So if there's something that can manage those side effects, that can be super helpful.
It was so interesting when I came across, I think I actually heard it at a meeting, and then I talked about it with the team. And like I said, I don't use a lot of 5-FU, but the team that does, they've incorporated it into their practice and seem to be very happy with it. So I always love learning from others, things that you can do better with taking care of these patients.
One other thing about thinking about managing or preventing toxicities, thinking about using other medications, non-chemo agents that you would use as a pre-med or as a concurrent medication along with a regimen. I'm thinking of one like 5-FU and methotrexate and leucovorin. How would that be working?
Real interesting pharmacologically. Now you're going to get my pharmacologic nerd part going. It's really interesting how leucovorin, which is a reduced folate, methotrexate works by blocking an enzyme that decreases the ability to make the folate that we need in our body to make cells. So one of the things that we do when we use really high doses of methotrexate is we let it work for 24 hours and then we come in and we give leucovorin, which is the thing that we've blocked. So you're coming in to rescue cells, and you're rescuing cells because the cancers we use high dose methotrexate, we know that 24-hour exposure is going to be a really good effect on those cancer cells. So that's why we use leucovorin after methotrexate. We use it as a rescue. We use it to minimize the toxicities that you would see with methotrexate. You decrease GI mucositis. You decrease the bone marrow suppression when you come in and adequately rescue with leucovorin. Now, that's methotrexate and leucovorin. Let's go to 5-fluorouracil and leucovorin. 5-fluorouracil blocks an enzyme in the production of thymidine needed for cells. It requires folate, a reduced folate, in order to get that good binding. So the reason we give leucovorin with 5-fluorouracil is to get better binding to our target, better cell kill, and actually we get more toxicity because we're getting better cell kill for the cancer. We're also getting better cell kill for normal tissues. So when we give leucovorin with 5-FU, we're giving it to potentiate the effect, but we also, what we get with that is the increased toxicity, bone marrow suppression, mucositis, diarrhea.
That is fascinating. And I'm going to go back to, I wish I'd known that a long time ago.
Well, I want to add one other one that you kind of like, I thought you were going to go to, and that is like pemetrexed. When pemetrexed first came out, and it is really a multi-targeted antifolate analog, one of the things that they found is that it was toxic, but they found if they gave folic acid and periodic B12, that you minimize the toxicities with both bone marrow suppression as well as with mucositis and diarrhea. And if you give dexamethasone, a corticosteroid, you decrease the rash that you see with it. So I think your point is really good. There are agents we give concurrently to help optimize the drug effect and to help modify the toxicities.
And I think the other piece of this that's really important is the drugs are tested or they have been tested in a certain way in a certain patient population with a certain tumor, that sort of thing. And many of these side effects, to the point that you made about with what you saw at ASCO recently, is that these medications are released and these are the pre-meds we need to use for it. This is what we know of the toxicities, but we don't learn about how to manage a lot of those toxicities until it's been used in practice for a longer period of time. And somebody says, I wonder if we should try this.
I can't agree with you more. I think one of the biggest challenges, I just had a situation that was not an antimetabolite drug I'd never used before. I couldn't find in the literature and through resources I normally use how to manage. So I actually reached out to colleagues to find out who have used the medications to say, what's your experience? What's worked for you? It's one of the reasons I really love ONS, because I think it gives a forum for people to ask those questions together.
And communicate what they've been hearing in their practices and saying, hey, the docs that I've been working with have been using this, the pharmacists have been recommending this, and really making it more of an interprofessional sort of practice as opposed to just reaching out to our own little groups.
Exactly.
Moving into some other questions, thinking about administering these medications, are there any considerations that the nurses should keep in mind when administering?
Well, these are chemotherapy and they're classified as chemotherapy. So chemotherapy handling is what you would do for most chemotherapy is appropriate here. They are not classified as, there's a phrase people use, DNA damaging, where they cause DNA strand breaks and things. And so some people feel they're less toxic in that way. But I still would say to use your normal mechanisms of handling, both with mixing administration and education for patient and patients' caregivers and families about how to handle secretions and things after receiving these drugs.
That's a perfect segue into my next question. What should be some of the primary patient education points to communicate to patients and caregivers about these antimetabolites?
I think that's very agent specific and probably even more so regimen specific, because I realize as I'm doing education, if I have a number of different drugs, it's kind of hard to do each drug separate and people to kind of follow you. So I think developing good patient education tools that people can take home that highlight the most important things about the regimen, including the antimetabolite aspects, making sure patients know what to monitor for so that they can contact their team if they need it. Diarrhea is something I always talk about with patients getting 5-fluorouracil. I do it because otherwise people self-manage and don't actually know what to do. And we really want to make sure that they contact us if they're having problems with diarrhea. I do a lot of education of things that patients can do to mitigate toxicities. So again, very agent specific. And I think that that should be both in verbal as well as written. As much as I love giving good written handouts, I know many patients won't read them. Some people will memorize them, but many patients, it's just too much. They're overwhelmed. So going over those high points of each agent really is important.
And I think going along with that, thinking about, it's not just a one-time education. It's really about the continued education as the patient is more ready to learn and less overwhelmed at the beginning of their diagnosis.
Oh, you are so right. I could not even agree more. It is so important. I do the first day education a lot, but I love seeing people mid-cycle and then next, just to kind of re-emphasize things to think of going forward. I can't even agree more.
100%. We talked about some of the collaboration that we can do between the pharmacists, the nurses, and the providers. Can you think of other ways that pharmacists and nurses can collaborate to manage these adverse events and toxicities?
I think one of the best things that people can do is work together in the development of the order sets, whether they be electronic or not. And so that within the order sets, there is clear indications of those things to highlight to patients, those strategies to take to manage. I think that's really helpful. And I think it's best done by a team. And to modify those order sets as things are learned that are helpful. So that, if the strategy is dose reduction, that's clear that that's going to be the strategy. So I think that in this day and age, it's really important that there is collaboration in developing whatever resources that we have. I guess that goes even beyond order sets to the education that we deliver to patients to make sure it's a consistent message. I think that is essential. The team knows what everybody's going to say so that it is consistent, because patients get so confused.
Exactly. And then they don't know who they should be trusting or who's the best source of that information is. And so I think if everybody's on the same page, then it's a lot easier for both the patient as well as for the nurses taking care of the patient and the provider.
I so agree. I really like knowing what other people are saying and learning from them. So I think that collaboration and that communication is essential.
I have one more question before we get to some of our wrap-up questions. This one's kind of interesting because it goes back to what you said. These medications have been around for a really long time. So when you talk about newer agents, they're ones that, I was mid-career when gemcitabine came out. So I think that it's not new. So what do you think the future looks like for this class of medications and what they might look like in the landscape of cancer care?
I've been thinking about that when I knew I was going to do this. And I think that there are certain agents that are so foundational in some diseases that they will remain. Whether they remain first line, maybe not. Maybe they'll go to second line as we see things evolve with new agents. Some of these drugs have been very effective in the diseases in which they are used to treat patients. I do think there's long-term place in therapy for these, and I think that we'll still be using these. The thing that I think we may find is additional uses. If you would have told me when fludarabine came out that it would be a mainstay in preparative regimens for certain transplants, I would have been surprised. And that now anybody would say, well, of course. So I do think that we still find ways that we can use these agents. I'll give you another example. Gemcitabine, which, as we both said, is not very new, but has been incorporated in the treatment of a lot of different solid tumors, even though it was developed for leukemia. But anyhow, so it's been incorporated into all these different treatments. One of the things with gemcitabine is it is a very, very strong radiosensitizer. So one of the places that we use gemcitabine is with radiation for, say, bladder cancer, because it is such a good radiosensitizer. There's still things we need to learn about these drugs and still new ways that they will probably be used.
That is a really good point. And I think that those are things that we find out after we've had it in use for a while. So it's so important to report the side effects and the toxicities that patients have been having so that we can get a body of evidence to start looking at doing something else.
I'm going to add just a little bit about that radiosensitizer because I got a little panic because gemcitabine is such a good radiosensitizer. When we use it with radiation, we use a very small dose, very small. We're not talking anything near what we use when we use it in combination chemotherapy. So when you have a patient getting gemcitabine, if somebody decides that they're going to do radiation, you have to make sure everybody knows they're on gemcitabine because you may hold the drug while they're getting radiation because you don't want an increase in toxicity. So I had to add that because as I was thinking of patients I've seen over the years and how important it is for people to be aware of that radiosensitizer effect.
That is a really good point. And it's about the communication, right, among the team. So
Yep.
Making sure that everybody can see what the patient's getting, but you're also making an effort to communicate it to the rest of the team to make sure everybody's on the same page. All right. I just have a few more questions for you. What are some of the common misconceptions about antimetabolites?
I think that people don't realize that there is such a variety of types of antimetabolites, that there are similarities as we've talked about, but there are some uniqueness in each subcategory. So the antifolates are very different than the purine analogs. And I think that it's important to kind of realize that all antimetabolites are not the same.
What's something about these medications that's often not discussed, but you wish people knew more about?
I think that probably with the oral antimetabolites, the capecitabine, sometimes people are not aware of what their actual mechanism is because they were kind of late comers to the treatment. So I think that it's really important to realize that even though something is an oral agent, it still may have the toxicity that an IV or intravenous agent may have because of how it works.
I think that's a really good point. And I think that was one of the things that when capecitabine first came out and that I was learning that the pharmacists that I work with were really clear with me that this was an oral agent that was eventually would turn into like the same type of product as 5-fluorouracil. And that helps cement it in my mind that these two are kind of the same. So I can kind of expect those same toxicities. If you don't have that opportunity to do that or you don't have that collaboration, it's hard to connect pieces together to help provide that education and think in your mind of what you should be looking for. To that point, what additional training or education do oncology nurses need to know to prepare for understanding antimetabolites?
And I think this conversation has made me think this even more. I think that there are so many new, exciting agents, and there are so many older agents that are still used in practice that it's becoming very difficult for people to understand the mechanisms of the drugs that we're using and the agent-specific toxicities. So I think that the education that's needed is the foundation and fundamentals of chemotherapy, because they still are used so much in practice. And I would hate to lose the knowledge that practitioners have because we're excited about the new exciting therapies that are new and exciting.
All right. This whole conversation has made me almost, I love my job at ONS, but it's almost made me wish I was back at clinical practice, providing chemo education to the nurses that I worked with, because it's just like made my mind just bend a little bit in how I would be providing that education. So thank you so much for this.
Well, it's funny because when I was thinking about this, I used to teach in a chemo course back when I first started in practice in Pittsburgh. And it was one of my favorite things I ever did. I learned more about the drugs, getting ready to teach them in that chemo course to healthcare providers, nurses, pharmacists. I was thinking the same thing, how much I missed doing that chemo course. So
exactly. Mo, it has been so great talking with you again. Do you have any final comments for us?
I think this is really helpful to go over the foundation of chemotherapy like that you're doing with the alkylating agent series and this. These drugs are still really important in practice. I appreciate them. Thank you very much for this opportunity.
Thank you for joining us.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.